Welcome back to the Derm Club podcast. As the population ages, having a strong understanding of geriatric skincare disease is important. Whether you are a geriatrician, primary care physician, or dermatologist, we are going to be increasingly involved in the skincare of more patients in subacute settings, adults, congregate living environments, and nursing homes. To explore the comprehensive dermatologic needs for the aging population, we are fortunate to have Dr. Daniel Butler. Dr. Daniel Butler is a dermatologist at UCSF, University of California, San Francisco, where he co-directs the Geriatric Dermatology Department. Dr. Butler is also one of the co-founders for the GeriDerm Expert Resource Group, a community of dermatologists who promote the health and appropriate treatment of older adults with skin disease. This is a topic very dear to my heart because I'm very close with my grandparents, and I am so happy to welcome you, Dr. Butler, to the Derm Club podcast.
Thanks so much for having me. This is exciting.
Let's get started with a question that both me and many others would love to understand. What is geriatric dermatology? Why is there a specialty around that?
Yeah, thanks for asking. This is something I really enjoy talking about, exactly for the reason that you brought up in the introduction, which is that I think it's personal for everyone. And that's how I'll circuitously answer the question, which is geriatric dermatology is a little bit different for all the stakeholders. So it's a little bit different for patients, it's a little bit different for family members, and then it's a little bit different for providers. And that's a fun way to think of a sort of this neo subfield of dermatology and internal medicine. And what I mean by it's different in all those elements is this is a population-based subspecialty. So we're sort of looking at all the influences on skin and aging. And sometimes those are directly related to sort of the personal and the patient experience. Like, for example, who's going to take you to an appointment? Who's going to get you from the car into the clinic? And then on the more scientific or provider side, geriatric dermatology also involves really nuanced pathophysiology of itching or the natural history of basal cells. So it's very expansive, and I get asked that question a lot, but it really is, under the umbrella, anything that impacts the skin of older adults. And there's really no age cutoff for it. That's another common question I get, what is geriatrics? I think we're even moving away from that word. So it's just aging. And, I think part of this also is that there's a big force in dermatology, and there's nothing against this force of anti-aging. And so we need a force on the other side that's pro this inevitability of aging. And I think geriatric dermatology is a little bit of that force as well.
Well, it sounds like I would have fun in your specific specialty, because I really love working with older people. And I'm curious for my own grandmother and other grandparents, until what age is it important for patients to have an annual body skin exam in the geriatric population?
It's another really good question, because it's a tough one to answer. I try not to make any distinctions on a number age, meaning I don't look at someone's age and then distinguish if this is someone who continues to need screening or evaluation. I think it's really contingent on what the patient feels comfortable with, mixed with what we know from the clinical or historical side is their risk. So here's a good example. If you have a 70-year-old, which I don't consider old, who has a ton of comorbidities, is being treated for a number of different things, and they diligently find their way into the dermatology clinic, and they're frail and they need a ton of help, and their other comorbidities are more substantial than what we're seeing on the skin, is that someone on that day that we have to treat an actinic keratosis on a lower risk area like their forearm? I think it's a legitimate question. And obviously I'm cherry picking some of these. They get much more complex. But on the other side of that, you can have a 95-year-old who walks into clinic on their own has been diligent to come in once a year for a really long time because they have a history of multiple keratinocyte carcinomas. And they're swimming 3 times a week. They're social. They live in a community setting, and absolutely, that's someone I'm going to treat as if they have plenty of life expectancy. So I think in that question of yours is like, what are the things that we have to look at that may help us really define someone's age more so than than the number of years that they've lived. And I think that's part of the fun of this growing field is determining what those look like, and then training the future of dermatology to start integrating those questions, those concepts into how we discuss plans with patients. So it's not that we're not doing it already, but I wouldn't say it's absolutely commonplace. So yeah.
It sounds like 90 is a new 70.
I hope so for everyone.
I hope I'm that latter patient. So how do you treat elderly patients? My grandmother often complains of her back being itchy, and it's frustrating for her. But at the same time, I avoid multiple medications, specifically antihistamines, because of their sedative effect. They can cause dizziness, falls, these are already concerns in the elderly population. How do you go about treating specifically itch, which I know itch gets worse with age?
It's another awesome question, because this is like the one of my career hopes is that we get more clarity in this. And this is a vast clinical problem. I mean, it is everywhere. And it's likely that people on this podcast who are listening to this or watching this will get itchy at some point. So it's huge, and it's a really challenging and fun challenge. It's a really challenging and fun thing to look into, because when you start to peel away the answer to that of how do we manage itch in older adults, there's so many fascinating pieces to the experience of aging. And I'm speaking sort of ambiguously, but what I mean by that is when you start to peel away why people itch and why older adults itch, you start to see that there are nuanced changes in the nervous system. There's nuanced changes in the immune system. There's nuanced changes in the keratinocytes, or the primary skin barrier. And all of those have this complex interplay in how they affect each other, and then ultimately affect the clinical outcome of itching. And when you start to look at those and you start to peel it away, it starts to make more and more sense, albeit it's still really challenging to be able to manage. So I talk about itch in those three, with those 3 contributors, because often that's how we target it. And the challenge is figuring out which 2 or which 3 are contributing to itch in a certain patient. So if someone comes in with fixed itch in their mid-back, and then fixed itch on their dorsal forearm, I'm thinking, okay, this is probably someone with a more neuropathic component to their itch. So I'm going to go down that treatment pathway. Or if someone has red spotted dots on the center of their chest, I'm thinking, okay, this may be more immunologic as its primary cause, and I'm going to go down immunologic pathways. But where this gets, again, more complex and more challenging is that older adults, as they always do, they never present cleanly. So there's always overlap, and it can be really challenging clinically. And this is where geriatric dermatology, we have so much fun, is that it's not the perfect setting to be able to look at someone and just make an easy diagnosis. There's a lot of complexity as you peel away those layers, trying to figure out what are the contributors to this patient's itch. And it's been a really fun thing for me and the other people involved in our Aging Skin Collaborative here at UCSF to start to peel those away and find targets for itching. So that's my first answer. The second answer is, then once you figure out what the contributors of the itch for a patient are, then you got to figure out how to treat it and treat it safely. So you brought up antihistamines. So for historical use, and then probably because of their ubiquity on the market over the counter, antihistamines for some reason have been just associated with itching. They really don't work for itching. They work pretty well to put you to sleep, and they work really well for histaminergic itch, like urticaria. So, you can use it in older adults for those in select circumstances. But for the most part, you're trying to find other treatments that are going to be safe that are targeted to your type of itch, which, antihistamines don't necessarily target the most common causes of itch in older adults, which I would argue are immunologic, that are not histaminergic, and then also neuropathic. So there are a lot of different treatments along those pathways, and we're actively trying to figure out how to determine if they're safe in older adults, and we need more studies to do that. So I welcome anyone who wants to help bring in a comfort with all the medications that we use, specifically in our vulnerable population.
Yes, and itch is kind of this new uncharted territory. And I just recently spoke to Dr. Brian Kim, who works at Mount Sinai for the Itch Center. I recommend checking out my podcast with him, where he really talks about the fundamentals of itch, and maybe there could be some collaboration there. So let's move on. We talked about itch. What are other common dermatologic diseases you treat in the elderly population?
Yeah, Brian and I have already gotten to work together, and I'm glad that we have brilliant minds like him looking into it, and then brilliant outgoing people like you being able to talk about it. So other than itch, the hardest things I find for dermatologists in older adults are the management of complex malignancies, as we see people with multiple comorbidities. That's certainly one that I see people get stuck on. I think nuanced presentations of complex immunologic diseases like bullous pemphigoid is another one where we have a really hard time managing older adults. And then the other one that's really common is ulcerations. So ulcerations specifically in the lower extremities or in contact areas, pressure areas. And I use the word ulcerations, but usually they're sores. Sometimes they're not even ulcerations. Those are the ones that I think are really, from a disease perspective, can be really perplexing for dermatologists. I would also argue that we don't really have great disease schematics for older adults. And so I think that there's a lot of things that we don't even know that we're missing in older adults. So here's an example. We looked at pyoderma gangrenosum, which I think schematically we all have from medical school a concept of what that looks like, which is like a 40s woman with inflammatory bowel disease and a non-healing ulcer on the legs.
You can visualize it as you talk about it.
Right, so that's kind of the schematic. But when we actually looked at a large cohort of pyoderma gangrenosum, we found that most patients with pyoderma gangrenosum were actually older adults with sometimes solid or hematologic malignancies who had multifocal ulcerations on their lower extremities. So it sort of breaks up the disease schematic. So I'm mentioning this because I think there's a lot of diseases where we have a schematic of what the disease is. And unfortunately, the presentation in older adults is a little bit different. I would also argue that atopic dermatitis is very similar to that, where we have really defined criteria of what atopic dermatitis is in younger adults and certainly in adolescents. But the atypical presentation in older adults almost makes them excluded from that diagnosis, and it makes it hard to include. So I don't really have, I've been saying this more and more recently, I don't really have a great idea of how many older adults have atopic dermatitis, or if I should be even calling older adults with sort of this eczematous chronic rash atopic dermatitis if they don't fit the classic criteria. So that's my long-winded way of saying, I think that there's a couple diseases, and then I think we also have to bring a microscope to some of our dermatology flagship diseases to get a better idea of how older adults are presenting with those.
I have something quite specific, but I've noticed during my practice where I see, I've seen patients across all populations and ages. And I always notice that in the elderly population, or in the aging population, that there is an increase in seborrheic keratoses. And we often tell the patient these are wisdom spots, or also the increase of cherry angiomas. And I know these are just two that I'm mentioning that these are two lesions that really do increase, it seems, with age. Why is that? And what are the best treatment options that seem to work to get rid of, maybe not specifically the cherry angiomas, but the seborrheic keratoses?
Yeah, it's those. That's I've never been asked that question, and I'm glad you did, because I'll be the first one to tell you I'm not sure exactly why seborrheic keratosis and cherry angiomas are more common in older adults. I usually sort of give the hand wavy answer of time and experience, but I'm sure there's some basic scientist out there or someone who understands the true biology of aging that could give us a better answer. I think you bring up a really good point, though, which is we sort of roll our eyes or brush away. And I'm being a generalist here, but when we see those things or hear those complaints, we sort of roll our eyes or brush away that those are that they're just benign, right? And I think it's a really important thing to remember that we should not ever make assumptions, particularly on older adults, if something's bothersome or not. So what I mean by that is, you have someone coming in, they're older, they have a bunch of seborrheic keratosis. In our eyes, that looks like a totally benign thing, but that may be really bothersome to them. Sometimes they can be inflamed and really itchy. Sometimes they may just not look great, and that's a quality of life impairment. And so we want to stay unbiased and make sure that we can meet the patient where they need to be met. And I certainly have older adults who have major comorbidities, even involving the skin. But the thing that they're worried about is the seborrheic keratosis. So certainly you can educate them and tell them, hey, this is not the thing you have to worry about, but you can also provide them with an ability to treat it. And so sometimes after counseling them on what to expect, I will absolutely treat these with liquid nitrogen or with a light electrodesiccation, just to try to get rid of them, because just having the ability to remove one of those can impact the quality of life. And you never want to get stuck on an assumption where just because they're older, they may not care about what something looks like or that something benign is growing on their skin.
Okay, and I want to talk about skin cancer. What is the likelihood, or how many folds does it increase for a patient over 65 to develop skin cancer once reaching that age?
Yeah, I think we're getting more sophisticated in being able to answer this. I don't have exact percentages, but I think when you start looking at specific demographics and specific types of skin cancer, melanoma versus non-melanoma, even some of the sort of offshoot dangerous ones like Merkel cell carcinoma, you start to see increases across all demographics as we age. So it's certainly a concern, and probably one of the most common things that older adults come to their dermatologist for. So it's an important characteristic to be able to use that characteristic of what exactly is your risk profile as you age is such an important thing for us dermatologists to have really good comfort with and be able to explore with patients. And there's so many different risk factors that would go into one specific patient, and being able to talk with them about those things can really help us as providers guide that discussion and guide the level of our clinical concern as we're going in to evaluate a patient or, hearing about their plight over the phone.
So what specific characteristics do you consider when you're assessing a patient and considering, like, okay, they're gonna either develop skin cancer, or should we remove this lesion? Should we leave it alone?
Yeah. So this is I feel like we could have an entire seminar on this. And again, there's no perfect answer to it. If you're seeing someone in clinic and you're worried about a lesion, I always get the question of, how do you treat a basal cell on someone who's 90, or how do you treat a squamous cell on someone who's being treated for cancer elsewhere? And I've never had a great answer for it, but I think I'm honing it down. And I think the answer to it is you talk with the patient about what they want. So I think there's this practice in dermatology, which is common and we all do it, which is like, we are hunters of basal cells and we are hunters of squamous cells. And once we find them, we know what to do with them because we're so well trained to be able to do those things. And I think when push comes to shove and there's a huge challenge, like you were telling me about your grandma, or I was telling you before about my grandpa who was in his 90s and had a basal cell. Ultimately, what we can do is engage the patient in what we call shared decision making and communicate with them what the risks would be of all the different options, whether that's clinical surveillance, whether that's a more half-measured option like a ED&C, or whether you want to go all the way down to Mohs for the patient for the treatment, which I think is great, which is a great option in some cases for older adults. You make sure that they know what the options are, because then you're able to engage what's important to them. You're able to communicate the risk to them. And then you're also able to create a treatment relationship. And that's so critical, because I often find that neglect of non-melanoma skin cancers can be really bad in older adults. So I always engage patients when I'm worried about a lesion to say, hey, if we're not going to do something today, I need you to stay engaged with this lesion, because I don't want to see you back in 3 years when this is twice the size. But in 3 to 4, 5, 6 months, that lesion probably won't change as much. So I'm talking about all these different factors that go into treating a specific lesion. And so I think it's a combination of our knowledge of these lesions mixed with the patient goals. And that should drive how often someone should be screened a lot of the time, as well as the treatment decisions of a specific lesion.
Is this the same thought process that you use when deciding between surgery and radiation for patients?
Absolutely. Absolutely. So, I think there's two schools of thought, and I think I believe them both. So when you have a concerning lesion on an adult patient who may have comorbidities enough to where there's going to be challenges with the treatment, there's two schools of thought. So one is you leave it and you watch it clinically before you treat it, and you make sure that they know what the risks are of it. We call that clinical surveillance, and that's been well documented as a successful treatment option for patients undergoing a number of different things at the time. And then the other option that I also practice and believe in is to biopsy everything and then decide thereafter. So I think a lot of it depends on the patient themselves for a concerning lesion and what they want to do. But I believe in both of them. And the biopsying first option, I think, gives you a little bit more data, which can be helpful in ultimately deciding if you're going to need to do radiation or further treatment, because the biopsy, even if it's small, is going to give you some important clinical characteristics, or I should say pathologic characteristics of the lesion. So we can combine our clinical and the path to be able to tell how aggressive this lesion would be. So for example, you may see a basal cell and you say, oh, okay, I think I'm pretty certain this is a basal cell. But then you do the biopsy and there's, it's micronodular. And now I'm a little bit more worried about it. Or, it looks like a squamous cell. Yeah, I can kind of tell that. Patient's undergoing other stuff. If we biopsy it, then we can ultimately see if there's any invasive element to it, or what is the level of differentiation. And that may dictate how aggressive we are, either surgically, radiation wise, or even just monitoring it. So I believe in both sects, and there's kind of, we're a little bit split in the geriatric dermatology community, which I think is good. Debate is always good. And I think everyone should have that discussion with their patients about which track they want to go on.
Yeah, that open communication is important. So what about actinic keratoses? These are often considered precancers, and I'm not sure exactly the amount of AKs that have been actually shown to turn into squamous cell carcinomas, but what is your threshold for treating AKs in elderly population? And the elderly patients, like my grandmother's 95, she probably has a few AKs that I could find. Do I go out of my way and get those treated? Or do I say, you know what, by the time that they're likely to even turn into something, it won't matter?
All great questions. And, you start to bring in the mix of the ethical and the clinical problem, which I think is really interesting and what makes this field so fascinating. As far as actinic keratosis, there's so many different studies that show the rate of conversion to an SCC, somewhere between 1%, 0.1%. And I think patients need to know that. I think the use of the word of pre-cancer for these can sometimes be over the top, or it can be misleading to patients. So I think making sure that they know those statistics is really important. And then I'm like a broken record, but going back to the patient and helping them understand what these lesions ultimately mean. So if they have one spot on a low risk area, is that really something that we need to treat? I think it's less likely that we need to treat it. If we have someone who's had a history of a invasive squamous cell, and now they have 15 on their scalp, even if they're 95, maybe I'm going to have that conversation and push a little bit harder. And then there's the last sect of the population that I think is really important that we acknowledge, which is aging transplant patients. So I would be remiss not to mention them, but that's a huge risk population and so different. And again, we go back to that initial part of the conversation we had, which is, it's not just an age. So a 79-year-old who, has a couple AKs, but no history of a transplant, versus the 79-year-old with 10 AKs who has a history of a transplant, those are completely different patients and how aggressive I'm going to be. So you want to be able to share that with the patient, let them make the decision using your clinical knowledge of their risk profile. So I use an honest conversation about what the conversion of an actinic keratosis percentage looks like, mixed with their clinical risk factors and what I'm seeing on their skin and in their history. So I know that's not a direct answer, but that's usually how we approach it. And I'll also acknowledge one thing, because you keep hitting on these really important topics, is like, this is not an easy conversation to have. And it's not built into the normal practice of dermatology, which is, and I love this part of dermatology, is fast-paced decision-making, moving, doing, procedural, room to room to room. And so that's where, geriatric dermatology is working to help people integrate some of these concepts into the practice. We're definitely not there yet, but hopefully in the future, we'll have really implementable ways to promote these conversations and make it easier for us all.
I'm sure you will, as the population ages and your clientele expands. So I'm assuming during the pandemic, and you can correct me if I'm wrong, that you did a little bit of telemedicine. So I see you shaking your head. Did you find this easy or difficult to treat patients using telemedicine? I know my grandmother, she wouldn't be able to use a computer if it wasn't for the help of my parents or her grandchildren. So what was your experience doing telemedicine with this population? And do you see it as beneficial or possible?
Yeah, I think there's a lot of hope for telemedicine in general for the aging population. And I think there's a lot of potential. COVID sort of pushed us straight into it. And I think that it was good in some ways and it was negative in others. I've had wonderful experiences with some older adult patients who are really tech savvy, and it makes it so that it's a huge convenience for their life. And then I had other experiences with older adults where it made them even sort of remove them further from the medical institution, because that became the standard of connectivity and they just couldn't do it or they didn't have help. So I think that it can only improve, but we have to be really cautious at a systems level to not continue to exclude older adults or those who are less IT engaged, because that's a huge risk of, yes, hypothetically, it would work really well. But I think for older adults, we're going to have to implement huge systems changes to be able to make sure that that access is still there. Mm-hmm. And there's a lot of people who are working on that. And I think ultimately sort of this COVID change to practice will push us in the right direction. But I think it was a little jarring at first, and it was helpful to a small percent of the population, but we have to be really careful moving forward that we're inclusive and engaging on a systems level to make sure that we're not leaving anybody behind.
Yeah, I totally agree with you. Like, I saw so many benefits of it. I can think of one specific patient who had several cancerous lesions on their legs, and they were using, I think it was like acitretin at the time. and we would be able to talk to them. And first of all, they had moved out of state during the pandemic in with their family, and they were able to contact us every week for follow-up, and it really helped. And not only that, but the family was able to be involved, and normally the family was either working or just not there at the time, so it made it much easier to have a conversation and to make sure that everyone was on the caretakers and everyone else was on the same page. How about adherence and compliance to medication in the elderly population, and in general? And does telemedicine seem to improve compliance?
It's a really good question, and drawing the line between the two, I don't have a great answer for it. Adherence is an issue with older adults, particularly with dermatologic medications, because we're often giving creams, and it does take some working of the body to ultimately be able to apply those to important areas. And then, just making sure that our recommendations and how to take this and how to do that are really clear. I think are even more important for dermatologic medications for older adults. And I'm not sure how telemedicine directly was implicated in that, but you do hit on one of the most important parts of geriatric dermatology, which is, beyond the treatment, can we actually deliver this treatment? And there's pretty good evidence that topical medications have lower adherence than oral medications in older adults, which have lower adherence than biologic or injectable medications. And so it's these types of little studies that are so critical for us, because we have to know that. We have to know that when we're going in, and that can help dictate how we approach the treatment. So I go in to my grandfather's bathroom where he keeps everything. And of course, all of a sudden I'm seeing 25 different creams. And I know his dermatologist is one of my best friends, but it's just, after years and years and years of going to the dermatologist, people just start accumulating these things. And you can see how adherence becomes an issue, and where it can become really dangerous. Like the most common one that I think we all worry about and have seen before is using Fudex in the wrong place. So those little things are so critical in older adults, and we need a lot of work on how to best manage adherence and think about it in this population.
So funny you say that, because I was just cleaning out my grandmother's bathroom, and I came across like 7 tubes of different steroids and different antibiotic creams, and anytime I try to put any topical ointment on her, she tells me it's too cold, she doesn't want it. So I totally understand where you're coming from. I'm assuming telemedicine may be able to help us in this regard, because you can kind of follow up with the patient more often and say, hey, just call them for a quick follow-up. Hey, did you apply your topical ointment today? So hopefully that's something that we can use to our benefit in the future. Where do you see the future of geriatric dermatology going?
Well, first of all, just acknowledge, I think that's such a great creative idea of, like how do you fix adherence or improve adherence with, connectivity. And that's a well-known concept. And I think, again, back to systems level, where I think, geriatric dermatology's future will have a lot of systems-based sort of management strategies or changes for its future success. I think that's a really great one. And I'll say we need more creative people like you to start thinking in that way of how we can improve these things. So, the future of geriatric dermatology is, it can go in any one of a million directions. And I think that's one of the cool things about it. I think of geriatric dermatology as a little bit of a step aside or a step away from a really disease-specific model that sort of academic dermatology has had to date, which is, we have melanoma clinics, and we have vesicular bullous clinics and connective tissue clinics, which are all great, and we should still have those. But then geriatric dermatology clinic is like a big bear hug for everything. We would see anything that comes in, and hopefully we would be able to integrate some of these systems changes to help what we can do from the specialty side, from the diagnostic side. And so what I mean by that is hopefully we would have systems that would promote our specialty. So geriatric dermatology clinics where the ergonomics of the chairs for the older adults are specialized for, for people who may have limited mobility. We would have clinics where people could easily either park or walk in without having to move a ton. Like you mentioned, to have follow-up schedules and abilities so that patients aren't needing to come in with a ton of regularity when it's really challenging for them to come in, and we can check in with them. And then also a huge integration with our primary care and geriatrics colleagues. And I think that future is really exciting because it really integrates us into the house of medicine. And I think those system changes will go right along with some of the basic science, clinical practice, research, educational things that I think are really exciting about geriatric dermatology. So the future of those are really understanding itch in older adults and development of medications that are specific and safe for itching in older adults. Same thing with including this in our educational paradigms. Like, how can we change the disease schematics that we all hold so dear, like atopic dermatitis or pyoderma gangrenosum or lower extremity ulcerations, and include these little disease nuances that we know about older adults that when they're little on the pathophysiologic level turn out to be really big on the patient presentation and clinical level. So that educational change is really exciting, and I think happening all over the country right now, with sort of a heightened look at this population. So that's my excited look at the future, and there's plenty of ways to get involved if anyone's interested.
I totally agree with you. I think that collaborative care and the use of digital health tools is really going to be implemented in the future and very helpful to improve the care of the elderly population. Dr. Butler, thank you so much for joining the Derm Club podcast today. I love speaking to you about this topic. My grandparents are very special to me, and anything geriatric related really resonates with me. So I really thank you for your time.
Thank you for having me, and I'm glad that it resonates so well with you, and I'm so happy that you bring this topic up. I think it's important, and I think it resonates with a bunch of people. I'm just like you. This started with my 4 grandparents and getting to see their experience with aging, and I had a good mentor who used to say, aging is your problem. So, everyone's going to have it, and it's an inevitability. So we may as well all jump on and try to solve some of the challenges that it presents for us. So thanks for bringing this up, and thanks for discussing it with me.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.